Hello, my name is Todd Bull. I'm a professor of medicine at the University of Colorado, where I direct our pulmonary vascular disease program as well as our Center for Lungs and Breathing. And I have the pleasure today of talking to you about certainly a difficult but common problem that we encounter in both the pulmonary vascular world as well as the parenchymal lung disease world, that is interstitial lung disease. So seen commonly in both pulmonology practices as well as cardiovascular practices, and that is the management of patients with group 3 pulmonary hypertension. And in particular, today we're going to be discussing in detail interstitial lung disease associated pulmonary hypertension. Certainly, again, a common problem, but a challenging problem in terms of management. So setting the framework for this discussion, that is the management or discussion of group 3 PH, as discussed, as I just mentioned, pulmonary hypertension often complicates this disease course. We see it and refer to it as chronic lung disease associated PH when we're thinking about it in aggregate. The etiology of ILD-PH is both complicated and multifactorial. We see differences in sequelae, pathologic sequelae among the different groups, though again, they frequently result in some degree of pulmonary hypertension. That is a common manifestation of these underlying parenchymal lung diseases, with the ending result of elevated right-sided pressures. And then it is incredibly important to do a hemodynamic evaluation of these patients when we are considering treatment. Treatment has historically been difficult, with numerous studies showing us really lack of benefit in intervening in terms of adding medications to WHO group 3 PH. But this is an evolving area, and one that excitingly seems that we may be moving into a place where we have some better ideas about how to treat these patients. But even in that scenario, there's patients that I think many of us in the pulmonary vascular world agree do merit intervention, though it has to be done with caution and with paying close attention to the potential sequelae of adding pulmonary vasodilators to this patient population. So starting out this concept of ventilation perfusion matching and that of hypoxia and vasoconstriction. And really the way I like to describe this, to think about it, is that really our lungs are quite smart, if you will. They recognize this very quickly through HIF, hypoxia inducible factor sensing, that there are areas of the lung when there's low oxygen that you do not want to send blood to those areas. You want to downregulate vasodilators, you want to increase vasoconstrictors, and then move blood away, if you will, from that portion of the lung that's not working. And so here we see an example of a lobar pneumonia. There will be local area of hypoxia here due to this dense infiltrate, and the lungs recognize this, and then very quickly, in fact, essentially immediately due to HIF signaling, are able to shift blood away from that area to another. Now, problems start to arise if you are more globally hypoxic. And so, for example, if you were sitting on the top of Mount Everest, in this case with oxygen, but if this individual was not wearing oxygen, then these lungs would be more globally hypoxic. And so vasoconstriction would be ensuing sort of throughout the lung as they tries to find areas to improve VQ matching. And this can result over time in the development of first initial pulmonary hypertension related to hypoxia, but then more of a chronic disease if that hypoxia is not resolved. And this, again, sort of is a concept that then occurs in parenchymal lung disease. If we have a lung that is significantly affected, in this scenario, by fibrotic lung disease, well, the lungs, again, are doing what they teleologically, if you want to think about it that way, should be doing, trying to move blood to the areas of the lung that are functioning, vasoconstricting areas, or downregulating vasodilators to these parenchymal basilar areas that are not. And again, so the lungs, this is its role. One of the big issues that we need to deal with is this concept of ventilation perfusion matching, or VQ matching. And certainly this is well recognized by pulmonary physicians, by cardiovascular physicians around the country and the world, but it does merit discussion because this is one of the big risks that we get into when we think about adding pulmonary vasodilators to patients with parenchymal lung diseases. And again, VQ matching really breaks into two broad categories. That is shunt, or physiologic shunt in this scenario. And that's a scenario where we are perfusing an area that is poorly ventilated, so an area of the lung that, for example, may be damaged, but sending lung or blood to it. And our body is smart. It makes a point of or certainly our lungs are smart of trying to avoid this scenario. And so when you have an area of the lung that is working or functioning poorly due to perhaps interstitial lung disease, COPD, other forms of parenchymal lung disease, the lung vasculature really is instructed to shut down in that area. Vasodilators are downregulated, vasoconstrictors are increased, and we decrease perfusion with an attempt to improve VQ match, send blood to the parts of the lung that are working, avoid parts of the lung that are not. And the opposite end of that spectrum is dead space or physiologic dead space when we have lack of blood flow to areas of the lung that are functioning well. But for this particular talk, it's really this physiologic shunt where really sort of most of the potential harm can ensue if we add pulmonary vasodilators to the wrong patient population. Really, the next big question becomes, what is driving this patient's symptoms or disability, if you will, in terms of severity? And is it being predominantly being driven by the parenchymal lung disease, that is problems with spirometry, with forced vital capacity, with diffusion capacity, with 6-minute, which can then impact obviously your physiologic function at 6-minute walk distance? Or is the primary determinant an issue of the pulmonary vascular disease, that is decreasing RV function, decreasing ability for delivering blood, cardiac output, cardiac index? And is there some point where one overwhelms the other? This, I think, is an area that can be difficult to tease out, but also important to understand. Again, when I'm approaching the individual patient, where does the primary problem lie? And I think carefully assessing both the physiology as well as the hemodynamics can help you decide, is this a patient that merits intervention from a pulmonary vascular standpoint, or really does the focus primarily reside in the parenchymal lung, and there's the potential for harm by adding pulmonary artery vasodilators to that patient? And again, this can be a difficult assessment, but really the way we tease this out is careful assessment of the patient's physiology in the context of these disease states. So here are factors that may sort of lead us more towards more of a group 1 phenotype versus a group 3. And again, the world is messy, if you will, and so patients can have phenotypes that are more typical of group 1 while still having parenchymal lung disease. Conversely, there are some disease states that are group 3 that end up with more severe pulmonary hypertension than we might normally expect from that patient group, and therefore may merit treatment along those lines. And so where are these factors? What are these factors that help us determine this? Well, obviously the clinical underlying substrate, are there risk factors for WHO group 1 disease, such as connective tissue disease, HIV, underlying liver disease, etc.? Are these in fact absent in group 3? What do the pulmonary physiology tell you, or the pulmonary function testing, in terms of degrees of airflow limitation or restriction, the impact on diffusing capacity, being more mild in those of group 1, or at least tending to be the case, more severe in the group 3 category? How about our imaging? Initially, frequently X-ray, but then with more sensitivity and specificity, moving to CT, the degree of fibrosis when we're talking about ILD. How about our non-invasive screening studies, echocardiography, which can be difficult to adequately assess, certainly both the RV and then also pressures when there's significant parenchymal lung disease, but an important test in terms of at least initial screening and looking at these patients. But then importantly, and I'll stress this throughout the talk, certainly when considering treatment in this group, it's really essential that there's a careful assessment of the true hemodynamics, not just the estimated, and hence invasive monitoring or invasive studies with right heart catheterization. What are the PA pressures? How is the cardiac output? What is the right atrial pressure? These are all important clues in terms of whether we should consider intervening from a pulmonary hypertension standpoint. So these again are, as I've alluded to, these are tricky treatment decisions. They really need to be individualized and considered carefully, because there is the potential for harm, going back to these discussions around ventilation perfusion matching. There historically has been lack of convincing evidence for efficacy and safety of group 1 PH medicines in patients with group 3. Certainly numerous previous studies have shown lack of benefit, and there is the potential for harm. So finding expensive ways to make our patients do worse, certainly no one's goal in this scenario. With that, I will stop. I want to thank you for your time and attention.